So welcome everybody to our discussion today on behalf of the New England MHTTC's Early Psychosis Learning Collaborative. I am excited to welcome all of you to the third of a series of online discussions on implementing real-world evidence-based services for early psychosis and clinical high risk for psychosis. My name is Michelle Friedman-Yakubian, and I'm calling in from my home in Cambridge, Massachusetts. And as you can see, there's all sorts of fun things in my background, including some home improvement projects. The goal of this series is to bring together leaders, clinicians, administrators, and other stakeholders who are interested in working together to increase feasibility and scalability of specialized early psychosis in clinical high risk for psychosis treatment. We have a great group of guest speakers in this series who have been sharing their experience with finding ways to make it feasible to provide high quality prevention services for youth and families who are affected by early psychosis or signs of clinical high risk. The format of each discussion in this series includes a 30-minute presentation by an invited expert, followed by 30 minutes of questions and discussion by participants. We really encourage you to also use these discussions as an opportunity to network and develop work groups to advance some of the initiatives that we discuss. Now my colleague Rachel is going to share with you some housekeeping information to help you get the most from participating in this discussion.
Hi everyone, this is Rachel. I'm the project coordinator for Early Psychosis Learning Collaborative. I just wanted to review a few housekeeping items with you all before we begin. Participant microphones will be muted at entry and you'll be able to unmute them during the discussion portion. During the presentation, if you have any technical difficulties or questions about the topic, please use the chat or the raise hand feature during the discussion to have your microphone unmuted as well. This discussion is being recorded and will be available for viewing at a later time on the MHTTC website. And to reach us after the webinar, you can email newengland@mhttcnetwork.org. And on our next slide, our MHTTC mission is to use evidence-based means to disseminate evidence-based practices across New England. Our area of focus is geared towards recovery through recovery-oriented practices and support services within the context of recovery-oriented systems of care. And please for the next slide. To ensure the responsiveness of our work, we will actively develop and maintain a network composed of different stakeholders from each of the 6 states to guide our activities. And finally, on our next slide, to learn more about us, you can visit our website as well. And with that, it's my pleasure to hand it over to Dr. Michelle Friedman-Yakubian for introductions.
Thanks, Rachel. So before I introduce our wonderful speaker today, one thing I just want to encourage people in this moment of varying connections, I really want to encourage folks to be willing to let go of shyness, especially during the last part of our discussion, and be willing to put their cameras on. Please do use the chat functions, and also you'll be able to ask questions directly and to participate in a discussion. So for folks that are willing to turn their cameras on, we really appreciate it. I think it makes the discussion more lively, more connected, and would appreciate folks who are willing to do that. So today we have a terrific presenter who's going to be leading a discussion on payment strategies for coordinated specialty care. And as the clinic director of a coordinated specialty care for youth clinic for youth at risk for psychosis in Boston, I think this is an especially timely discussion as the need for coordinated specialty care is greater than ever, while there's great economic uncertainty in the world. And we certainly know this could have a big impact on grants and other funding sources for these important programs. The implications of the current pandemic on access to coordinated specialty care has clearly had an impact, but the economic impacts on it are still yet to be determined. So I'm delighted to have Melissa Rowan here today to talk with us about her work. Melissa Rowan is the Executive Vice President of Policy Implementation at the Meadows Mental Health Policy Institute, where she brings a practical, real-world focus to the Institute's work in health systems and with service providers. Melissa has worked on a range of Institute projects with a primary focus on service expansion, quality improvement in real-world settings, and healthcare financing. Before joining the Institute in 2019, Melissa was a partner at Wertz and Rowan, a healthcare policy consulting firm she founded in Austin. And she has worked in and around Texas and national behavioral and health systems for 25 years, focusing on broad healthcare issues, managed care, and behavioral health. Melissa has previously served as Healthcare Policy Director for the Texas Council of Community Centers in Austin, working closely with the 39 community mental health centers across the state on innovation and design of behavioral health programs for adults and children. She has also been appointed to the boards of the TMF Health Quality Institute and LifeWorks, as well as serving as Vice Chair of the HHSC Behavioral Health Integration Advisory Committee. She earned her MSW from the University of Texas at Austin and an MBA from Concordia University. Welcome, Melissa Rowan.
Thank you. It's so nice to be here today. I really appreciate the opportunity to participate in this important discussion, the series that you have on early psychosis, and to share with you some of the work that not just Meadows Mental Health Policy Institute did, but did with a large group of contributors. Just a little bit about the Meadows Mental Health Policy Institute, in case you're not familiar with us. We are based in Texas, and our mission is to support the implementation of policies and programs that help Texans obtain efficient and effective mental health care when and where they need it. And so I am in Austin, in my home in Austin, Texas today, and it's really nice to be here with you. So a little bit of background on the paper that I'm going to talk to you about today. In August of 2018, with support from the Bowman Family Foundation and the Meadows Mental Health Policy Institute, a group of national advocates and experts again collaborating to develop a financing model for early psychosis treatment programs that could be used by commercial insurers, with Medicare, and with Medicaid. As you can see, we had a large group of contributors who had work group representatives participating in the discussions and working with us to collaboratively review various models of care, staffing and cost models, billing strategies to work with insurers. Contributing authors to the paper that I'll talk to you about today include Brenda Jackson and Kathy Sternbach, senior advisors for the Institute. And Brenda is participating in the discussion with us today, so I will, when we get to the Q&A section, call on her to contribute. Dr. Lisa Dixon from Columbia, Dr. Henry Harbin, who is an MHPI board member, and Dr. Michael Schoenbaum from the National Institutes of Mental Health. And whenever his name comes up, we always say, and I have it written here so I get it right, the views expressed here are those of the authors and not necessarily those of the National Institute of Mental Health, the Department of Health and Human Services, or the federal government. There were also multiple other contributing voices and reviewers to this paper and this strategy. So here you have the link to the paper if you would like to access that on our website so that you can read in more detail. I'll cover the approach today, but there is more detail in the report. So the goal of the work group was to identify a billing strategy to deal with the fact that traditional billing does not cover the full cost for a CSC program. In addition to professional medical services that often are billed, there are many other parts of the CFC program that are not reimbursable at this time. We wanted to identify a billing strategy that could work to fully support a CFC program, and the goal was to identify that using existing billing codes, rather than having to generate a new billing code through the APA process. Getting a new billing code takes a lot of time, so the work group really focused on finding an existing code that could be used. And then we also wanted to develop guidance for providers and insurers for payment of early psychosis treatment. As you know, if you work in a CFC program, the cost of early psychosis programs are similar across programs that operate in fidelity to the research-based models. They're billing separate individual services, but it doesn't compensate for the non-face-to-face professional services, collateral contacts, community-based services, daily team meetings, outreach, training, and documentation requirements. And so in looking at all the things that go into CFC, this group really focused on a strategy to pay for both the professional and rehabilitative services through a single case rate, similar to what you might find for partial hospitalization program, where one rate covers a variety of services. There is an existing HCPCS code, if you're familiar with medical coding, that can be used for early psychosis programs, and that led to the recommendations that you'll find in the white paper that's been published. So the first finding is that we believe that there's a single rate for everything that encompasses a CFC program will result in fair compensation for what's being delivered and in fidelity to the national research standards. This allows these programs to really be supported without having to rely on grant funding, which, as those of you who have worked with grant funding know, grant funding comes and grant funding goes. And so really, how does this become a sustainable healthcare service? And so we recommended two different reimbursement structures, but based on the code T1024, that could be paired with an HK modifier to indicate a full month of the service provider was provided, or one without a modifier for an encounter rate. And I'll talk more about what the difference is between what we call the full model and the encounter rate, so that you have a little more understanding of what that means. And if you don't do a lot of healthcare billing, some of this code language may not resonate with you, but it's just a standardized way that's been defined, and this particular code works well for the type of services in CFC. It is HCPCS instead of CPT code, so HCPCS codes are more often reimbursed by Medicaid than by commercial insurance, but there's no prohibition for commercial insurers using those codes. So it is available for commercial insurance, Medicare and Medicaid, which was part of the goal in this project, was to find something that would work across the different types of payers. So the full model includes a monthly case rate to reimburse for all of those services that we talked about that are required for fidelity to the model. People would have to meet target criteria in order to receive CFC for the full month, and then there would need to be some monthly minimum standards about what an insurer could expect you to provide in order to qualify for the full case rate. It could include, and this is just some suggested guidelines, all of this is negotiable with the insurers, but when the work group talked, we talked about that you would have 2 to 3 face-to-face visits or HIPAA-compliant telehealth contacts from one of the team members. There would be at least one collateral contact, either telephone, email, a phone-based app, or telehealth, and a team meeting with all staff from the team, including the licensed professional from the team. So those things would have to be done to qualify. to bill a full model case rate. But that's the minimum. So this must include all the medically necessary services in the CSC program beyond the minimum that individual might need that month. So there may be some months where someone's getting a lot more than the minimum, and some months where they're just getting the minimum. There would be some things that need to be clearly defined in order to bill a case rate. Admission criteria to the program, including how you define who is qualified to participate. Recommendations for care, supervision, and treatment plans developed by a licensed practitioner. And we put that in there because we thought it was important for insurers to realize some of these services are delivered by non-licensed staff, which is completely appropriate and meets the requirements of the model, but they are under supervision of licensed practitioners. There would be some minimum staffing required for the program, the minimum number of encounters required in order to bill the case rate, and then discharge criteria. At what point should someone be transitioned to another level of care and shouldn't remain in the CSC caseload receiving the full monthly case rate. The document that we've published has an appendix that offers a draft proposal for admission and continued stay guidelines. And there's still additional work to be done on what that might look like. But I think if you are in discussions with insurers, it's a good place to start. We also felt like there were times where someone should be in the CSC program, but they are, for whatever reason, at a less intensive pace. And so they wouldn't meet the minimum criteria for the full case rate model. But that doesn't mean that you want to discharge them from the program or that you shouldn't be paid for the services being delivered. And so that's where we proposed the encounter rate. So you would bill for each encounter, but it would be less intensity and less reimbursement than the full CSC model. And some of the reasons why this might happen is someone may go into the hospital on the 5th day of the month. And so if you're not seeing them the rest of that month, it's not appropriate to get a full case rate, but you may have seen them the days before they went into the hospital, and you would be reimbursed for that. There may also be transitions to step down levels of care. Someone's doing much better, but they're not ready to leave the team. And so we wanted to be able to provide a way to be reimbursed for that. Or if someone, for whatever reason, leaves your geographic area for some extended period of time in that month, but they're coming back. So those are just some examples of when an encounter rate versus a case rate would be used. So that's the link again for the paper. I think conceptually it's pretty, I think it's pretty easy to understand if you think about how we do other services, and partial hospitalization is a good example of that, where you bundle those payments together. So there are costs required to operate a CSC program to fidelity that are not individual billable services. And so how do you get all that wrapped into one rate so that we're really supporting people with the model as we should be? So I think at this point, we're going to open it up for conversation. And there's been folks who've presented in the series already have talked about some work they're doing in states, and some of that's been tied to similar types of strategies as what we have here. And I know that there've been, Illinois had some work, Maine's had some work. So there's been work going on where they're trying to tie in reimbursement into a more, into a case rate model that would pay for the full scale of the CSC program. So if you've been working with insurers on models like that, we would really like to hear about those today. And I think Brenda Jackson's on the line, so I might put her on the spot first to see if she might be willing to talk about some of her work in Oregon, which really was foundational to this, the concept concepts that we're talking about here, and some other work that she's aware of in different parts of the country. Brenda, are you on?
So I believe at this point, folks, actually, Melissa, if you advance the slide one more, it gives a little bit of instructions on how folks can unmute themselves and allow themselves to be seen on camera. So hopefully Brenda's out there and can unmute herself. And if we close out your slides, we probably can all see each other a little bit better. So folks will have an option. You can either type in thoughts into the chat or just go right on to speak, but you do need to unmute yourself in order to do that. And I think everyone has the option of doing that now.
Hi all. This is Michelle, another Michelle from Cedar. I'm curious to hear more about any barriers you might have encountered in coordinating this with insurance providers. Like, do you have trouble getting folks to the table? Did insurers have any specific concerns that you needed to work through, like in proposing this? And thank you for joining us.
You're welcome. Thank you for having me. The concept paper we haven't put that into action. That's why I was hoping, because some of the other people who were involved in this process have been talking with insurers. And so I was hoping maybe some of those folks were on the line to see, now that we have a concept, how those discussions are going. I know in some of the conversations we've had in other forums about this, there's been a little more openness in the Medicaid world and probably more confusion in the commercial insurance world. And I do think part of that is TSC has kind of come from, the funding for it's come from SAMHSA and been more of a discussion in the public sector. So Medicaid state agencies are used to hearing about things like mental health rehabilitative services, where commercial insurers are not. So I do think we have a lot more education to do to explain that in the commercial insurance world.
Yeah, I definitely love to hear more on that. I've never done any of that sort of process with actual insurance providers, so I wouldn't even know where to start doing that. It's like if you need kind of a team of people in order to encourage insurance providers to agree to a meeting or to start this sort of conversation. Just like email the boss of Blue Cross Blue Shield. Like, I have no idea where you'd start.
This is Kathy Adams from Michigan, and we did just that. Actually, we started with some of the leadership of some of the major insurance companies. We reached out to our insurance commission in Michigan. We're not too far down the road, but I'm taking some notes here in terms of like the appendix as a Melissa, you mentioned that as a good tool to kind of start that conversation. But understandably, the insurances are very interested in the numbers. They want to know how this makes a difference in the dollars and cents and the overall kind of quality of life, I suppose, for their members. So we had to have that information at the ready. And I think ESA has a really nice kind of, and I think Illinois does as well, like a template, as kind of a legislative brief they prepared to take kind of to the legislature, which I think had some utility with insurance as well.
I can say this in our negotiations in Maine. Are people hearing me?
Mm-hmm.
Yeah. Well, it's has had its ups and downs. An initial step was simply, well, not so simply, getting our own medical system to believe that this really made sense. And that took some doing, because what we're constantly swimming upstream against is, and I hate to just use the overworked word of stigma, but, mental health issues are not seen on the same par as heart attacks and strokes, even though, maybe they darn well should be. Particularly when you're talking about the major illnesses with psychotic features. we kind of chipped away at that. I worked on that in a couple of different stages, and the group in our medical system, which is called Maine Health, included this in negotiations for a whole package, their whole package of behavioral health services. And we had this sort of manic and then depressed response to all of this, in that initially all the companies just signed on to all the whole darn package, including coordinated specialty care for first episode. And so I was running around saying, hallelujah, we're free, we're all set, right? And then it's like they got around to reading the fine print of what they'd signed, and now some are discussing with us the fine print, and some are saying, hey, wait a minute, we'll get to you later, and later could be, decades from now. I was going to say I'll be old and gray, but I'm already, pretty gray. That's variable. We have some insurance companies that really want to continue the discussions once we could get the pandemic out of the way. And so, like, 2 of the 5 major companies that deal with our state are in a discussion. The other 3 are going to be harder to bring to the table. And the recurring thing that we run into is the sense that this is a small piece of the big healthcare picture. They see numbers like, gee, schizophrenia is 1%, lifetime prevalence, depression is 15%. So we'll talk to you about depression in the benefits packages that we're going to, have for large employers in the state. But we'll get to that 1% business later on. Well, I've come up with some figures I can't cite off the top of my head, but I can send those out, maybe send them to Michelle to distribute, that I've seen in some papers. Basically, the lifetime cost of these illnesses is huge. And we all know that. We're preaching to the choir here. And so it's a small number of people in the population, but they disproportionately cost a ton of money. And again, this is just forgetting issues like quality of life and doing the right thing. Minor issues like that. But the fact is these people do cost a lot of money. And so, and I've seen some comparisons that even though you have fewer people in the, many more people in the population, let's say with depression, their cost per individual is radically lower. Not that depression is a trivial thing, and some people are catastrophically ill with it, of course, and there's suicides. It's not trivial. But the point is, what we're dealing with first episode psychosis is not trivial. And so that takes recurrently kind of beating the band and putting the numbers in front of people. I had an interesting discussion with an organization here in Maine which represents employers' benefits managers. They help sort of organize the healthcare benefits. It's called the Healthcare Purchasers Alliance. I'm sure there are such organizations elsewhere. I haven't looked, but they too kind of thought this was going to be a hard sell because the focus is on the big items, heart attacks, cancer, stroke, and much less so on mental health at all. And then within mental health, the things that come to mind most frequently are big things like depression, anxiety, and comorbid substance abuse. So anyway, I think we just need to have to keep chipping away at this, keep presenting very real numbers to the people who are accountable for those numbers. And also, I keep trying to emphasize that, unfortunately, from the RAISE studies, we have very good data on this. RAISE studies and Vinod Srihari's program in New Haven, very good evidence that a payer, whoever that is, Medicaid or commercial, is going to see savings in the very same fiscal year. If we start coordinated specialty care on January 1st, you're going to pay more than you otherwise might have paid for outpatient services, but you're going to avoid a substantial number of hospitalizations, and there's going to be a net savings in the first fiscal year. So we're not talking about the terrible lifetime cost of schizophrenia. We're talking about the cost in 2020 of schizophrenia to you, the employer, and to the insurer. So I think we have to just keep coming back to the very specific hard numbers. Interested in how this has gone with you, Kathy, and Melissa, and others around the country. How we get people to the table, how we get people to pay attention.
Well, this is Kathy again. We did partner with NAMI. We call it a FEP Coalition with our state Association of Mental Health Boards, and with NAMI and me and other people kind of representing the work out in the field. And it has been a slog, and we're actually going to have a consult with, we're working on logistics with Mark Fagan from Thresholds in Illinois, just to try to kind of, how did they get there? And I think Mark says, when we were at that meeting, Doug, he says it took like 2 years, I think. It was a long process, and it's hard, to keep your, keep from feeling depleted. But I totally agree with you that we have to have numbers. We have to be able to speak intelligently about these things you were just talking about, in terms of, psychosis spectrum illnesses aren't tending, because of the lower incident rates, we don't tend to put an eye on that. But over the course of it, and like you said, even in the short term, there's an argument to be made about what kind of cost is going to be kind of realized in that year. So I feel like you have to be really well informed, and you have to kind of bolster yourself to feel depleted by it. Sadly, that has been my experience. But you have to kind of rally some forces. I think you got to bring together some stakeholders who have a shared vision on some of these things, and NAMI was a huge one for us, and they made psychosis their early intervention, their policy priority in Michigan. So we're kind of trying to rally in that way, but I can't deny feeling a little discouraged at times.
And I do think for states that can get their legislatures involved on defining benefits or healthcare, or adding reimbursement rates into Medicaid, that gives a significantly additional leverage to those states moving forward, because there's someone else involved in the discussion that has regulatory ability to make statutory changes. I think the interesting thing that I find in a lot of the conversations is that we always have to go to whether or not this saves money and doesn't save money in the year. But if you think about childhood cancer, when a child gets sick and we know what the best treatment is for that child, no one says, well, are we sure they're going to get better? Are they going to get better in a year? Is that treatment going to cost us less than if we did this other treatment? We say, this is important for this child's life, and this has been proven to be the effective treatment for that. And that's everyone's expectation for what should be paid.
Yeah.
But in the end, we also have to have, because of where we are in conversations about mental health, the other piece too, which is the financial piece. But it's not a lot of people, but there are other very rare diseases that insurers pay for treatment on all the time, where it's not a lot of people, and the treatment's really expensive, and sometimes it works and sometimes it doesn't. And I think that kind of discussion is more compelling at the legislature than sometimes it is with insurance companies.
Yeah. And there's no, we can't shy away from the value of testimonials from families, because we can't shy away from the emotional factor. I mean, this is reality. We have to tell people that this really makes a difference in people's lives. And pretty inevitably, somebody on the other side of the table has a son, daughter, spouse, family member who's dealing with this, and they know what you're talking about. So, I mean, I catch myself sometimes talking too exclusively about the numbers and the dollars, but we need to be focusing also on the reality of treatment. I keep wanting, someday I'll waste a weekend looking for this reference, but long ago I found a there was something in the New England Journal of Medicine, an article which was like the ultimate in cynicism about this, but to a point that to the level that it really made a point. It basically said, for comprehensive, thorough treatment of diabetes, is this cost effective? And basically, the answer was no. It's much cheaper to just let them have the damn heart attack and die. Pardon my, cynicism here. That's the cheaper way to go. And to help somebody, manage their chronic illness and live a nice, long life, it costs something. And we all make the decision that that's worth doing. There's no controversy about that whatsoever. So, and heaven forbid, you've got leukemia, and many people get cured, and many people have very good lives. And if we just looked at the fact it's going to cost you $250,000 in the next year, that doesn't make us decide not to do it. Now, fortunately, I do think the numbers line up on the right side for this. We do, it does in fact make better economic sense to do the right thing than to ignore this. Because if you ignore it, these people come back and it costs you anyway. They come back to your emergency rooms and your homeless shelters and so on and so forth. We all know that. Anyway, I guess we just have to hit both arguments.
I think some really important things are being said. And just want to call attention to a few things that folks have written into the chat, just in case folks can't see that. So some folks have written in just a lot of comorbid conditions are typically related to superutilization for Medicaid or high utilizers of employer plans. Someone used to work with them for 5 years. Melissa, that's so important about insurance paying big money for other costly treatment. Very important point. At the end of the day, this is an issue about a population of people experiencing active oppression. And we've tried to determine who on our legislature has family experience that has been open about it and focus on them to be partners in drafting legislature, in addition to collaborating with our NAMI partners for lived experience stories. It's clear there's so much wisdom across this group, and that in the potentially strength in numbers and working together could potentially have an impact on one state over another.
Michelle, this is Dave Shern. For the life of me, I cannot turn my camera on. So although I'm not very attractive to look at the moment, I did try to turn the camera on. This is really important work, and Doug and Melissa and Mark and several of us are on a work group that the PEPNet is supporting to try to continue to push forward with the work that Melissa and all of her colleagues have done such a great job in terms of teeing up the issues. Just a couple thoughts. We actually had a meeting yesterday of the work group. One is that according to Ken Duckworth, who's the medical director at NAMI, he thinks this is an easy sell to insurers. And he also works half-time for Blue Cross Blue Shield, helping them evaluate things that they should cover, et cetera, et cetera. And Doug mentioned Vinod, and Vinod had approached the Blues in Connecticut, and they were willing to play. He ran into some technical issues with the Connecticut Mental Health Center and their reticence, as I understand it, to bill commercial insurers, since they're a kind of a wholly owned subsidiary of the state in some ways. So there was a technical issue, and Vinod is still working on that. I have a question for Melissa. Melissa, so we have a code, and it seems as though it's appropriate for this type of CSC service. How do we then go about establishing a rate for the service? Is that done on an individual insurer by insurer basis? So let's say we have a specialty program. We can argue that it's the kind of program where not every insurance company is going to want to build their own, right? Because like Doug said, the relatively lower incidence says that what we need is a sort of a specialty practice that really knows how to do this and do it well. I'm just kind of figuring out, how do we get this in action? Is the rate established in a negotiation with each of the payers separately? What's the role of the purchaser? Doug mentioned the purchaser. What are some of your thoughts about how to move things forward that and sort of technically?
I think from a technical standpoint, I mean, ultimately, insurer rates are a negotiation between the provider and the insurer. And so we have components of what's in the case rate, but costs are going to vary by provider due to geography, due to different types of staffing. So it is individualized in that way, and particularly on the commercial insurance side. So I think it's a matter of the provider organization knowing what their costs are and what a rate would look like, and taking that to the insurer for negotiation. On the Medicaid side, it can be different in that states typically adopt a fee-for-service rate schedule. So a state could set a rate for their fee-for-service program, and I'll just use Texas as an example. And our almost all of our Medicaid program is in managed care, and we have multiple insurers. The state doesn't tell the insurers what to pay in Medicaid, but the Medicaid fee-for-service schedule still exists, and a lot of the insurance companies look to that on how they pay providers, and then things are individually negotiated with each provider. Theoretically, although a lot of times they're just paying the Medicaid fee-for-service rate. But so I think in Medicaid, much like Medicare, if the government sets the rate, then that kind of at least sets a baseline of where the conversation starts. On the commercial world, it really is much more individualized. If you're dealing with large employers who are self-insured, you know, that's also an interesting place to think about, because particularly if there's someone in leadership at the employer who has experience and sees the value in providing this as a service, then that large employer is determining what the benefit package that the insurer is going to offer is going to look like. So it kind of depends on the type of insurance we're talking about. And I think Brenda's on now, and she, I think, would probably have some thoughts on this piece too. Brenda, do you want to add anything to what I said? Probably have to unmute.
Can you all hear me now?
Yes.
Okay. When we've worked with providers and insurers and state Medicaid agencies in the past, the first thing that we need for providers to do is to figure out their unit cost. And so each provider has to do a calculation themselves to find out what the cost of providing the CSC is. It typically, what we found is that providers, when they're calculating their unit cost, they forget to come up with and incorporate the low cost or the low caseloads, the increased supervision, the enhanced travel and supply costs and overhead that are associated with it, the training and certification costs, as well as the lower productivity due to the certification, the training, the travel, et cetera. So when we've worked with, for example, providers and MCOs, the second thing then that has to happen is that oftentimes the MCOs have to make the case to the state, or the provider makes a case to the MCOs that they are cost effective. Sometimes states will require the health plans to pay at least the fee-for-service fee schedule. And in the states like New York where that does occur, then when the state sets the government fee schedule, then if that service is actually in the state plan, it actually automatically goes over and affects the MCOs. Now that happened for the first 2 years in New York, but the first episode psychosis program was not on the fee schedule. So they missed the opportunity there because it wasn't a fee schedule fee. Other states have been have been able to get that Medicaid fee schedule then to come over. One of the things we also look at is if you're not looking at the fee schedule and you're not doing a cost-effective alternative, a lot of times, for example, we have a couple clients right now that are using their mental health block grant funds to pay for at least the training and the enhanced costs that are over and above the Medicaid fee schedule. And where that happens, we do find that those are not financially sustainable initiatives, because the block grant funds are going to eventually be redirected to other sources. And so looking at the totality of unit costs, making sure that the fee schedule includes the totality of unit costs, making sure that you're paying for that totality and that it's calculated accurately become important. I don't know if that answers your question precisely, but when you actually do have the unit cost as a provider, then you know whether or not you should be signing the contract with the insurer.
It sounds like there are lots of considerations to make when figuring out what the fees are, and that's certainly going to differ from state to state, depending on cost of living and rent and all the different kinds of things that go into thinking about what goes into developing and running coordinated specialty care programs as well. One of the things I mentioned is we do have a speaker that's going to be coming in June who has developed a kind of a tool for trying to figure out rates to use. So we'll, folks who have questions about that will have an opportunity to see kind of a demonstration of that tool and to be a part of thinking about how to use that as well. Someone also wrote into the chat, curious about timing in initiating discussions with Medicaid or other funders based on the stage of program development. They're funding a first episode program through a block grant and have been in an expansion development, including coordinated specialty care teams, training, fidelity, creating manuals. The teams are up and serving individuals, but it seems like it would be useful to have established first in order to promote the value of the need for a full model rate bundle. What are the thoughts on that?
And when we typically see providers initiating conversations, it can be in very different places. If you have a program up and running, most states do have what's called an in lieu of calculation or cost-effective alternative arrangement, where if you go to a Medicaid managed care provider, a managed care plan, and you can document that it is a cost-effective alternative, many of the states we work with, and Texas is one of the very few examples where they do not have this, but across the nation, most states have a way that a managed care plan can negotiate an alternative payment arrangement and a comprehensive payment arrangement with a first episode psychosis team, especially if they can prove that it's cost effective. There are typically standard forms that are filled out. And so in the case that Kim is talking about here, we would recommend that if you are already funding this through block grant and you know you have Medicaid and Medicaid managed care clients, go ahead and start documenting this. If you need assistance with this, this is one of the things that we could provide, you know, an example of, perhaps. But there's no harm in just going ahead and asking for it. Now, some states are much easier than others to get that approved in. And so just knowing where your state is with that and how your MCOs are open to that would be very important.
That's a really good point.
In Texas, we are, sorry. I was just going to say, Brenda, in Texas, we are currently more clearly defining the in lieu of services options. And
Right.
CSC is one of those things that we're working to make sure is clearly defined so that there is more opportunity for that discussion to happen. And I think since you already have a program up and running, some of the things that you can show is also like hospitalizations before and after, and things like that show that, you know, some of the benefits of having this in lieu of putting someone in the hospital, that this program helps keep people out. So in some ways, sometimes it's hard when you start as a block grant because you're not thinking about that from the perspective of the insurer, but in one of the advantages, you actually have some real data about the individuals that you're serving and what their experience was with the healthcare system before and after your involvement.
What's interesting too is that Pennsylvania used the in lieu of to negotiate for a couple of its programs a bundled cost-based rate, and they hired Mercer to do an actuarial study, which actually, as I read it, turned out to be more of an opinion on Mercer's part that this would be cost-effective. There wasn't a lot of data in it. It was very interesting, but it was sort of like the state had a premier actuarial group tell them that this certainly could be an in lieu of service, and they used that rationale. But then it's sort of reduced to what kind of what Brenda was saying, where each individual provider or special CSC team has to negotiate with their local MCO to establish the rate. And at this point, I believe only two of the many teams in Pennsylvania have chosen to negotiate that. But the in lieu of provision, and it's great to hear Brenda say that that's very common, because does that come with, is it just the 1915B waiver, or is it more general than that?
And David, I actually am very familiar with Pennsylvania, so I can actually specifically and generally address your questions. So generally, we're not talking about a B waiver or an 1115 waiver. We're talking about capitation. The in lieu of has to do with the reimbursement between the state and the MCO, where because they're receiving an insurance payment, the insurance company can then choose to use their funds in a cost-effective manner if they can document to the state the clinical efficacy and the cost-effectiveness of that. In the example that you're talking about, there were a couple of very unique facets there. First of all, in Pennsylvania, one of the reasons that many of the plans and the providers have not negotiated with the behavioral health MCOs in Pennsylvania is because right now, first episode psychosis costs are considered to be, by the state at least, paid for by block grant funds. And the state has a philosophy that in general, they do not want the Medicaid plans paying for that. And so you just need to be very cautious of when there is a very specific payer representative that believes a very particular thing, that tends to happen. The second thing is in that particular analysis that you're talking about, which I'm very familiar with, keep in mind that Medicaid cost effectiveness of evidence-based practices for things like cost in lieu of services in a capitated environment probably do not come to the rigor of an academic level. And by design, they do not. So what you may think of as a cost-effective analysis is not what an actuarial firm or a Medicaid agency or even the Centers for Medicare and Medicaid Services would be looking for. Many states are able to go into, for example, the Washington State Institute of Public Policy and look at their cost-benefit analyses of mental health provisions, and they're able to just use those cost-benefit analyses that have already been done and bring those over and show, hey, there is this research that shows this particular evidence base and this particular cost effectiveness. And it may seem a lot like opinion, but in the cases of these Medicaid in lieu of analyses, the idea is not to spend more documenting cost effectiveness than the actual provision would save to begin with. So it doesn't lend itself to going to academic rigor. It lends itself to using widely available academic papers or cost-benefit analyses, which probably, if you're a very rigorous researcher, is going to come across as not terribly rigorous. Is that helpful, David?
Yeah, that's terrifically helpful, because I was thinking of the much more more academically oriented, but no, that's very helpful, and that's so that in some sense that lowers the barrier substantially. And I'm really glad you mentioned the Washington site, because that is a gold mine of
yes.
of ROI.
And it's the Washington Institute of Public Policy. It's WSIPP, and they have. I'm responding to Jessica's comment. There is on there are cost-benefit analyses for multiple mental health conditions, and when I used to work at the Centers for Medicare and Medicaid Services, and I was one of the first people who helped put this in lieu of together. And the idea is that it's so long as there is a solid evidence base for an evidence-based practice especially, then there should not be a large bar that anyone is jumping over. So to the extent you're talking about first episode psychosis consistent with a RAISE model, multisystemic therapy, FFT, anything that has a solid evidence base of being an evidence-based practice, then you should be able to document that's cost effective, and you should be able to get a alternative payment arrangement, value-based purchasing model, bundled methodology under a capitated system with no major effort, and certainly not having to recreate the wheel.
I just want to thank folks. I'm realizing we are just about out of time. This has been a fantastic discussion. There's clearly so much wisdom amongst our guests as well as many of the people that have participated in the discussion. If possible, I would greatly appreciate it. Folks have mentioned papers, resources, links. If you wouldn't mind emailing those to me or to Vanessa, please do so, or even add them into the chat so we can also post them along with the recording of this discussion today. Also, David, you mentioned a working group. If you are interested in having people join forces or add to that working group, please let us know in the chat as well, or by emailing me. I think it sounds like there's a lot of wisdom, ideas, and a lot of folks independently in their states kind of trying to figure out how to do this. And they're going to benefit so much from learning from what folks have already, the pioneers in this, have already been able to learn as well. So really just also want to thank you again, Melissa, for sparking this wonderful discussion and doing this really important work on behalf of patients and families that are affected by these experiences. And I hope that we'll be able to have all of you on again to join for future discussions. Next Wednesday at this time, we do have guest speaker Ian Lang, who is the executive director of the Brookline Center, which is the organization that our Cedar Clinic is a part of. He's going to be speaking specifically to measuring outcomes and what kinds of outcomes that insurance companies and payers want to see when they're considering whether to pay for these services. So hope folks will register for that, and we'll see you next week and going forward. Thanks again.
Thank you.